this video, we are going to discuss about drugs that promote sodium in water excretion, that is diuretics. Based on primary site of action in the nephron, diuretics can be classified into various types. Drugs like carbonic anhydrase inhibitors act on the proximal convoluted tubule. Loop diuretics act at the thick ascending limb of loop of Henle. Drugs like thiazides act at the early distal tubule. Drugs acting at the late distal tubule and collecting duct are called potassium-sparing diuretics, while osmotic diuretics act on the entire nephron. The tubular cells have sodium-potassium ATPase which pump out 3 sodium and bring in 2 potassium. Thus, the tubular cells are naturally deficient of sodium. This causes exchange of hydrogen ions with luminal sodium with the help of sodium-hydrogen antiporter. And the lumen hydrogen combine with bicarbonate to form carbonic acid. Carbonic acid dissociates into carbon dioxide and water with the help of carbonic anhydrase. Again, CO2 and H2 diffuse into the cell and form carbonic acid with the help of carbonic anhydrase. The carbonic acid again dissociates into hydrogen and bicarbonate. The hydrogen is exchanged at the sodium-hydrogen antiporter and the cycle repeats, whereas bicarbonate is diffused into the interstitium. Thus, the end result is the formation of hydrogen ions and absorption of sodium ions. This cycle is interrupted by carbonic anhydrase inhibitors, thus no sodium is exchanged with hydrogen and is excreted along with bicarbonate, resulting in alkaline urine. Let us look at the uses of carbonic anhydrase inhibitors: glaucoma, to alkalinize urine, mountain sickness, and epilepsy. These are contraindicated in liver disease due to decreased excretion of ammonia in the absence of hydrogen ions. This class of drug also causes alkaline urine, so it will cause worsening of metabolic acidosis in COPD patients. As usual, there is efflux of sodium from the tubular cells. In the thick ascending loop of Henle, there is sodium-potassium 2 chloride cotransporter. Accumulation of potassium into the tubular cell causes the loss of potassium through potassium channels. Positive ions like calcium, magnesium are repelled by potassium and are absorbed through paracellular pathway into interstitium. Loop diuretics like furosemide, bumetanide block the sodium-potassium 2 chloride cotransporters. This large amount of sodium and chloride are excreted along with water since these ions pull water along with them. Loop diuretics also increase the excretion of calcium and magnesium. Now, both carbonic anhydrase inhibitors and loop diuretics increase sodium excretion. This sodium, when reaches distal convoluted tubule, gets into the tubular cell through sodium channels and exchanged with potassium. This potassium, when accumulated, gets excreted through potassium channels. So, both of them also increase the excretion of potassium ions. As discussed, loop diuretics can cause hypokalemia, hyponatremia, hypocalcemia, hypomagnesemia, and metabolic disturbances, ototoxicity, or hypersensitivity. Loop diuretics are used in edema, hypertensive emergencies, and hypercalcemia. In the DCT, sodium chloride symport takes place, and sodium is as usual exchanged with potassium, whereas chloride is diffused into the interstitium by chloride channels. Also, the calcium from the lumen diffuses into the cell by calcium channels and exchanged with sodium. Thiazide block this sodium chloride symport. Thus, sodium and chloride are excreted in the urine. Since cells are deficient of sodium and sodium is excreted in the urine, the cell now needs more sodium. So, more of calcium is influxed and exchanged for sodium. In this way, calcium absorption is increased. Thiazides are used in hypertension, edema, hypercalciuria, and diabetes insipidus. Adverse effects are many like hypokalemia, hypercalcemia, and others. In potassium-sparing diuretics comes aldosterone antagonists and drugs like amiloride and triamterene. Aldosterone enters the cell and binds to specific mineralocorticoid receptor in the cytoplasm. This hormone receptor complex then enters the nucleus where it induces synthesis of aldosterone-induced proteins. Spironolactone is an aldosterone antagonist which competitively blocks the mineralocorticoid receptor. This formation of AIP is blocked. These aldosterone-induced protein increase sodium reabsorption and help in expelling out more K+ from the collecting duct. Spironolactone block the formation of AIP and thus is called potassium-sparing diuretics. Uses of aldosterone antagonists are edema, CCF, Conn syndrome, and adverse effects are hyperkalemia. Directly acting drugs like amiloride and trimetrin directly block the sodium channels and hence increase sodium excretion and retain potassium. Directly acting drugs like amiloride and trimetrin are used in hypertension, hypokalemia, lithium-induced nephrogenic diabetes insipidus, mucociliary clearance. Adverse effects are hyperkalemia, nausea, vomiting, diarrhea, etc. Osmotic diuretics mainly act in the loop of Henle and proximal tubule. They draw water from the tissues by osmotic action and result in excretion of water and electrolyte. Osmotic diuretics are used to reduce intracranial tension, reduce intraocular pressure in acute glaucoma, shock, dialysis. Adverse effects are pulmonary edema, headache, nausea, vomiting, etc.